Dr. Vikram Shivkumar is a neurologist with Orlando Health Neuroscience and Rehabilitation Institute Neurology Group. He specializes in movement disorders, caring for patients with conditions such as Parkinson's disease, Lewy body dementia, essential tremor, dystonia, Huntington's disease, Tourette syndrome, and others. In addition to caring for the patients, he also serves as the Institute's Division Director of Movement Disorders. Dr. Shivkumar earned his medical degree from MGM Medical College and Maharashtra University of Health Sciences in India. He then completed his postdoctoral training at the University of Toledo Medical Center with a residency in neurology and fellowship in movement disorders. He is certified by the American Board of Psychiatry and Neurology and a member of the American Academy of Neurology and Movement Disorder Society. Dr. Shivkumar also has served as the principal investigator for multiple clinical trials pertaining to treatment of Parkinson's disease and essential tremor. He's contributed to 3 book chapters and published numerous peer-reviewed articles in medical journals. Additionally, he is a professional reviewer for 8 medical journals and a frequent speaker at Parkinson's disease support groups, and that's how I had met him. Thank you so much for joining us today.
Thank you so much for the introduction. Good afternoon, everybody. I'd like to thank PMD Alliance for having me to give this talk. I hope you can hear me clearly. All right, awesome. I'm just going to get my screen shared here. Okay. Can somebody just confirm if you can see the screen? Okay, perfect. Awesome. So I'm going to talk mainly about the non-motor symptoms of Parkinson's disease and what we can do about these different symptoms. And the way I'm going to approach these various symptoms is we're going to talk about what you can do as a patient and what your physician might be able to do for you for each of these conditions. On every slide, you might see a percentage, which basically talks about how often this might be seen in patients with Parkinson's disease. And you'll see a range there because the prevalence or how often it's seen tends to vary a lot between different studies. So just to give some sort of an idea with regards to how often or how likely somebody might be to get these symptoms. However, not every patient gets every symptom or every non-motor symptom in Parkinson's disease. So this is just to give a fair idea. Let's see, all right. I do not have any disclosures. So before we go into the non-motor symptoms, I think it's important to first understand what are the motor symptoms of Parkinson's disease, and because the motor symptoms are what define Parkinson's. So the main feature of Parkinson's is bradykinesia or slowness of movement. So the way we test this out in clinic is we have you tap your fingers, open and close your hands, etc., to see how quickly or what the amplitude is in terms of range of movement. So that gives us an idea whether there is bradykinesia or not. And then you need to have one of the other 3 features, which is either rigidity, which is checked by manipulating your joints to see if there's a type of stiffness, whether you have a tremor at rest, and if there is any evidence of postural instability, which is not caused by any other cause, such as visual issues, cerebellar issues, etc. So contrary to, I guess, a common misconception is that tremor is the most common symptom of Parkinson's disease, but however, it's actually slowness. So about 20 to 30% of patients with Parkinson's might not present with a tremor. Other motor features include a smaller handwriting. The voice becomes softer. You have decreased facial expressions, smaller steps while walking, reduced arm swing, loss of dexterity, and dystonia, which is basically where your fingers or toes might curl and which might be painful. So those are the main motor features. Now, going into the non-motor features, you could kind of divide them a little bit into early and late symptoms. So early symptoms would be loss of sense of smell or constipation. And the thought process is that Parkinson's starts elsewhere in the body, maybe in the nasal mucosa or in the in the stomach, which is why these patients often have loss of sense of smell or constipation for years before the onset of what we call as the motor symptoms of Parkinson's disease. In addition, depression and anxiety can also be pre-motor symptoms or happen very early on, as well as REM sleep behavior disorder. REM sleep is basically that phase of our sleep where you have dreams. And during this REM sleep, in normal body physiology, you have what we call as atonia, as in your body goes limp. So you cannot move your arms and legs during your dreams. However, in REM sleep disorder, what happens is because of the fact that the Parkinson's affects a different part of the brain stem or the back portion of the brain, you end up acting out your dreams. So that can also happen for even decades before the onset of Parkinson's. And the later features tend to be more of cognitive symptoms, hallucinations, etc. Now, cognitive symptoms and hallucinations, if they happen very early on, then it makes the diagnosis more likely to be Lewy body dementia or dementia with Lewy bodies instead of regular Parkinson's disease. So, drooling, what can you do? You can chew gum or have hard candy. Now, the reason most people drool is not that they're producing too much saliva. It's actually more of a bradykinesia where you're just not swallowing often enough. And because you're not swallowing enough, you tend to drool. So if you're chewing gum or hard candy, then it tends to trigger a swallowing reflex, which helps reduce the amount of drooling. In terms of medications, we can use a pill called glycopyrrolate, or we can use drops, which are atropine drops. They're actually eye drops, but we can put it in some water, like 10 to 15 ml of water, just swish and spit it out. And that usually helps dry out the mouth as well. Or we can also do Botox injections. Now, the challenge with the pill is that, as I mentioned earlier, Parkinson's can affect memory and cognition. So when you're using a medicine such as glycopyrrolate, which affects the levels of a certain chemical called acetylcholine, it can sometimes worsen cognition. So we have to be careful. The atropine drops, on the other hand, might be relatively safer. And otherwise, we can do Botox injections. So the botulinum toxin injections are given in the parotid glands as well as the submandibular glands. And it's something that we inject every 3 months, which usually helps reduce the amount of drooling. Excessive sweating, pretty much the same things that we can do. Glycopyrrolate, drops, Botox injections, but in this case, the Botox injections are given by dermatology as opposed to for drooling, which most movement disorder physicians do it themselves. Loss of sense of taste and smell. Unfortunately, not really anything that we can do about it. We haven't seen any improvement in this symptom with any of the regular Parkinson's medications. Trouble swallowing food. This is not an early symptom, happens much later on in the course of the illness. Things that you could do would be to avoid hard, dry foods. So certain food consistencies might be more difficult to get down. So when we talk about difficulty swallowing, it could be either where you feel that the food just doesn't go down easily enough, or you end up choking. So if you avoid certain drier, harder foods that might be easier to swallow, sit up and eat, take smaller bites, and swallow before speaking, because you don't want to try to speak at the same time. That would increase the risk of it going down the wrong way. Increasing the dose of Parkinson's medications might sometimes help, but sometimes, especially in the later stages, it might not really make a difference. So then we send patients for speech therapy assessment. We also do a barium swallow study where they give you a contrast material and see if it's going down the right way or not. Speech therapists can also do a thing called vital stimulation, where they can stimulate the neck muscles to try to strengthen those. And in very advanced cases, if you're not able to tolerate regular foods, let alone or even modified diets like soft, mashed foods, etc., then we might have to talk about getting a feeding tube. But the feeding tube is usually very, very unlikely to be needed in somebody with regular Parkinson's disease. Nausea, this can be challenging. Nausea can be from Parkinson's itself. Sometimes a lot of the dopaminergic medications can do it too. Especially your levodopa, your dopamine agonists such as Requip, etc., can also cause nausea. So sometimes what we do is, if it's coming from the levodopa, then adding some more additional carbidopa can help alleviate some of that nausea. Or we have patients take the pills with crackers or non-protein food with the medication. The reason for that is proteins in foods can sometimes interfere with the absorption of the medication. So that's why we recommend taking it some non-protein food if possible. And you can also use ondansetron, which is a antiemetic medication. There are two other antiemetic medications, namely Reglan or metoclopramide and Compazine. These are relatively older medications, but these are best to be not used in patients with Parkinson's because they block dopamine in a more potent fashion. So they would then make your Parkinson's symptoms worse. Constipation happens quite commonly. We usually recommend people exercise regularly, hydrate. You want to drink at least 48 to 64 ounces of water daily. Increase your fiber intake. So bran or prunes. We might also recommend that you try some Metamucil or stool softeners or Miralax, which is a laxative. Bladder dysfunction happens frequently, and usually the presentation is increased frequency of urination and increased urgency. So when you get an urge, you have to get to the bathroom immediately, otherwise you might have accidents. So again, this happens from the Parkinson's itself. Now, of course, it's important to make sure that you don't have any other issues, such as an enlarged prostate, for example, in males. But if everything else checks out, then it's most likely due to the Parkinson's. For that, we can give some medication, such as oxybutynin, mirabegron, or which goes by the brand name Myrbetriq. The problem with especially oxybutynin, and to a lesser extent with the other medications, is that because they block a certain chemical in the brain or certain chemical in the body called acetylcholine, just like those pills that we talked about for the drooling, these pills can also potentially worsen memory and cause more constipation, hallucinations, etc. So if somebody has significant cognitive issues, then we have to be very careful when we're using any bladder medications. So in such circumstances, I prefer to actually send patients to urology, because the urologist can do Botox injections into the bladder, which will help relax those bladder muscles out, so that, and thus reduce the amount of frequency and urgency. Fecal incontinence is very, very rare. It's not common at all. The main reason it might happen is if you have really bad constipation, have not had a bowel movement, and then you end up having like overflow incontinence. But typically, fecal incontinence is not common. Seborrhea or dandruff is something that can happen too. We typically recommend washing hair and skin regularly with soap and shampoo, or using selenium sulfide shampoo over the counter. Not related to the dandruff, but you want to always look out for moles that are growing in size, because Parkinson's disease patients might have a slightly higher risk of developing melanoma. So you want to make sure that if you have a mole, that you're looking out for it. Leg swelling, typically this happens because of gravity. So when you're just sitting with your legs dangling, there can be fluid accumulation in your legs. So we typically recommend at least elevating the legs or using compression stockings. Sometimes certain medications like dopamine agonists, like your Requip, Mirapex, and Neupro patches, can also cause leg swelling. So if that is the case, if it's significantly more because of that, then we try to reduce those medications. But it's also very important to make sure that there's no other cause for the leg swelling, because just Parkinson's disease is not the only thing that could cause it. You want to make sure that your heart, your kidney, and your liver function is completely okay. Double vision, this happens because of a defect in a function called accommodation. So typically when we're looking at something nearby, our eyeballs tend to kind of converge so that they can focus on the nearby object. However, in Parkinson's, this accommodation phenomenon gets affected, so you're not able to converge your eyes to focus on the nearby object, which is what results in the double vision. So what you could do is you could keep the reading material further away so that you don't have to try to converge as much, or use larger prints again so that you can use it, so that you can see it from further away. The other option is to see the doctor and see an ophthalmologist and get prisms in your glasses, which can also help with focusing. Pain. This is, again, a very challenging symptom to treat in Parkinson's disease. And that's because most of our Parkinson patients are older people who already have other potential comorbidities. Maybe you have a bad back, bad hips, bad knees. So it can get difficult to tease out how much of the pain is purely from Parkinson's versus how much of it is being contributed by other conditions such as arthritis. So there's different types of pain. So you could have either a more of a musculoskeletal pain, which is mainly from with the muscles and the joints, or you could have more of a dystonic pain where you have curling of your toes and fingers and you have cramping basically in your muscles. Now, if it is mainly musculoskeletal pain, then maybe stretching, massages, warm bath, Tylenol can potentially help. Again, this is only for the Parkinsonian component. It doesn't really address the arthritic component if there is any. And if it's more of a dystonic pain, then we might have to, again, maybe think of Botox as an option. So for my patients with dystonic pain, where their fingers curl down, etc., I tend to do Botox injections again every 3 months, which helps to relax those muscles out and thus reduce the pain as well. Other things that we could do, if it's more of a dystonic pain, then we also need to figure out whether it's more of an off dystonia or an on dystonia. So very briefly, so off period is when your medications are not really working, they're worn off. So in those instances, you need to increase your Parkinson's medications to reduce that off period. However, sometimes if you're getting too much medication, or with Parkinson's disease, as it progresses, people might get dyskinesias where you start having wiggly movements. So dystonia can happen even as part of dyskinesia, in which case we might need to lower the medicine or adjust the timings of the medication. Other medication that we could use for the dystonic pains would be gabapentin and baclofen. Again, if you have neuropathy in your feet from, say, diabetes or something else, then that can also contribute to pain as well. Weight loss, I would recommend that you keep a watch on the diet, make sure you're getting enough proteins, enough calories. Try using Boost and Ensure shakes, which can also help improve the weight situation. And also with your physician, you might want to discuss and make sure that you don't have any significant dyskinesias. So if you're having very bad wiggly movements, then that's going to potentially cause weight loss as well, because you're constantly using a lot of calories because of the dyskinesias. Weight gain, relatively less common. The main reason this might occur, if it does, would be because of impulse control disorder. And I'll talk a bit more about this later in the talk, but basically what this is going to be is because of certain medications, certain dopaminergic medications, you might feel the urge to keep eating frequently, and this can result in weight gain. So if something like that's happening, then we need to accordingly reduce or stop some of your medications. Mild cognitive impairment and dementia. So the main difference between the two is that when we say mild cognitive impairment, it means that somebody is having cognitive issues, but if they have dementia, it means that the cognitive issues are prominent enough to the point where they are interfering with day-to-day activities. So maybe they need help with their medication. Maybe they cannot manage finances anymore. Maybe they cannot drive very well. So there is some difference between the two. Now, again, these are later symptoms. Mild cognitive impairment could happen within a few years, but dementia typically 7, 8, 10 years into the illness is when, if it happens, it'll happen. So from the patient standpoint, we typically recommend staying active physically and mentally. So regular exercise using puzzle books, etc., might help stimulate and reduce or at least delay the onset of dementia. From a physician standpoint, what I typically do is go over the list of medications, make sure you're not on any medicine like oxybutynin or something like that, that might be potentially contributing to the memory issues. And then we can add a medicine such as rivastigmine or donepezil, which basically increase the levels of the chemical acetylcholine. As I mentioned earlier, the oxybutynin or the glycopyrrolate, which are used for drooling and bladder dysfunction, decrease the levels of acetylcholine, whereas this one will increase the levels. So it might help boost the cognition. Hallucinations. There are multiple reasons why people with Parkinson's could have hallucinations. So one is the disease itself. So as the disease progresses, if somebody has dementia, then they might be at a higher risk for getting hallucinations. The other reason would be from the medications themselves. So all of your Parkinson's medications, be it carbidopa, levodopa, the dopamine agonists, amantadine, or trihexyphenidyl, benztropine, these are multiple medications that are often used. And these medications themselves can lead to hallucinations. And thirdly, if you've been, hypothetically, you've had Parkinson's for a while, you've done well on your medications, you've not had side effects, and one day randomly you're just super confused, you're having hallucinations. In those instances, it would be very important to rule out other causes, such as a UTI or a kidney dysfunction that could also lead to hallucinations. So if somebody has hallucinations, then we see if we are able to reduce any of your anti-Parkinsonian medications. Of course, the downside is if you reduce any of these medications, that might result in worsening of your motor symptoms of Parkinson's. So it's something that we have to be careful and understand where we have some wiggle room. Maybe we can reduce one of the more likely medicines to cause hallucinations, so such as, we stop the benztropine or the trihexyphenidyl and maybe go up on some other medicine in its place. Other things we can do, we can add medicines to block the hallucinations themselves. So if we are not in a position to reduce medications, then we can add either the rivastigmine or donepezil again to try to boost the cognition. We can use certain medicines that will block these hallucinations also, such as clozapine and quetiapine. Clozapine is a medicine that requires a lot of blood count monitoring regularly, so it's not something that we typically go with. Quetiapine is another medicine that we could use, but one of the potential risks is that it might cause drowsiness. So we try to limit its use during the daytime at least. Then about 6, 7, 8 years ago, there was a newer medicine that came out. Its name is pimavanserin. And it is a novel drug in the sense that it doesn't block dopamine, and it specifically blocks a different chemical called serotonin, and it is quite effective in blocking hallucinations as well. So hallucinations or even delusions, for that matter. Now, with all of these medications, we might not be able to eliminate hallucinations completely. The goal is to significantly reduce it. I mean, ideally, take it away completely, of course. But if not, at least improve them to the point where the person has insight into these hallucinations. So when somebody has hallucinations, they might have insight where they feel or where they realize that, okay, that bug that I'm seeing is not real. I know this. Or that person I'm seeing in the house is not real. But as Parkinson's progresses, or these hallucinations might get worse, to the point where you lose that insight. So the goal is to at least reduce the severity of the hallucination if you're not able to eliminate it completely. And as I mentioned earlier, if the onset of hallucination is sudden, then it is important to rule out what we call as delirium, which is basically altered mentation caused by other causes such as UTIs, etc. Depression can be seen quite commonly, again, can be a premotor symptom of Parkinson's disease. And we typically treat depression the same way we would treat any other patient with depression. We typically use what we call as SSRIs or SNRIs, which are different types of medications which increase the level of a chemical called serotonin. So some of these names that you might have heard of, like citalopram or Celexa, Paxil, Lexapro, etc. And anxiety quite often goes along with depression, and you can try relaxation exercises and pretty much the same medications that we talked about for depression, we can use it for anxiety too. Some patients with Parkinson's might also experience some anxiety as a wearing off phenomenon. So as it becomes time for your next dose, you might experience some anxiety as well, which gets better with regular levodopa rather than needing an antidepressant medication. Apathy. Now, apathy is basically lack of interest in doing something. So family members might notice that you tell the patient to exercise, but they don't feel like doing. They tend to sit on the couch. They don't want to do anything. So apathy is part of Parkinson's disease, and unfortunately, there's not a whole lot you can do about it other than trying to motivate regularly. Dopaminergic therapy often doesn't help. Rarely it might. Sometimes we might give some stimulants, but we have to be careful with stimulants because those can potentially increase heart rate, potentially cause blood pressure issues, etc. in older people. So we have to be very careful with using stimulant medications. But the best thing that we can do is to try to motivate the patient on a regular basis to get up and get moving. Fatigue, very difficult again. Not a whole lot you can do about it. Again, stimulant medications don't really have a lot of options. We typically recommend short naps. You don't want to sleep 2 hours, 3 hours in the middle of the day because then your whole sleep-wake cycle gets affected because then you cannot sleep at night. So it kind of it makes the cycle worse. So small naps, regular amounts of exercise. Often what we see is people feel drowsy after they eat food. So it's very important to stay active physically and mentally. Do something, games, puzzles, etc. to avoid sleeping too long. Coffee might help. Small frequent meals. So heavier meals might result in issues as well. Sometimes medications can also contribute to fatigue. So especially levodopa can. So it's just something that you have to watch out for. Lack of sleep, again, you want to avoid long daytime naps. Short naps in the middle of the day are okay relatively, 30-minute power naps, as opposed to trying to sleep too many hours in the middle of the day. Stay physically active. Sleep hygiene is very important. So you want to use the bed for sleep. You don't want to use the bed for watching TV. Reduce the amount of caffeine that you have, reduce the amount of soda that you have. If you're staying active, exercise regularly, but do that more so earlier in the day as opposed to late in the evening. Your physician might try to give you some medications to try to promote sleep, such as Ambien or clonazepam or melatonin you can try, which is over the counter. Melatonin, you can try even 10 or 20 milligrams of melatonin per day. Melatonin is a natural sleep aid. Our brain itself produces melatonin, so you would just be supplementing that. Sexual dysfunction, mainly erectile dysfunction, can happen too. So typically we would use medications like Viagra, Levitra, etc. for that. You have to be careful if you have pre-existing heart disease because that might be dangerous. However, if the sexual dysfunction is primarily related to an impulse control issue, then we need to reduce your dopaminergic medication. Orthostatic hypotension, you want to make sure that you stay well hydrated. Drink at least 48 to 64 ounces of water every day. Increase salt intake if you're not hypertensive. Avoid big meals, because when you have big meals, what happens is that a lot of the blood supply gets diverted to the gut, so there's not enough blood available to go to the brain. So typically what happens is when you stand up, you get dizzy. So what you could also do is elevate the head end of the bed. So what that does is when you eventually do stand up, that drop is not going to be as pronounced. So rather than going from completely flat to going upright, now you're going from, say, an inclination of 30 degrees or so, and then you stand up, so that drop is not going to be as significant. You can also use compression stockings, because what's happening is when you stand up, blood is pooling down into your legs. There's not enough blood coming back up to your heart. So when you use the compression stockings, it can drive the blood back up to the heart. If you're frequently getting dizzy, then you probably should give yourself a minute after you stand up. Don't be in a hurry to start walking, because that dizziness might not come on immediately. It might come on even a minute or two after. So you don't want to then get dizzy. Maybe you're going downstairs or going upstairs, because then that would be dangerous if you fell down at that time. So take your time before you start walking. Your physician might consider recommending your primary care doctor to reduce your antihypertensive medication, especially if you're on like diuretics that cause you to lose fluid. Just to add with regards to fluid intake, when we say 48 to 64 ounces, we talk about water. You don't want to drink too much soda or caffeine drinks, because they often result in loss of fluid. And we can use other medications such as pyridostigmine, midodrine, fludrocortisone, or droxidopa to try to boost the blood pressure, so that when you eventually do stand up, that drop isn't as pronounced, or at least your blood pressure doesn't go as low. The main concern that we have with these medications is that they could sometimes cause what we call as supine hypertension, where when you lay down, your blood pressure goes too high, which would then put you at a risk for stroke. So we recommend avoiding these medications later in the day, and to sleep with your head end elevated, because that way, again, you're not flat, so the blood pressure doesn't go as high up comparatively. REM sleep behavior disorder, as we talked about earlier, it is a premotor symptom. So we typically recommend using bed rails to protect yourself from falling off the bed, using pillows, mattresses, etc. In terms of medications, we can use melatonin at night, or also use clonazepam, which can also help reduce these episodes. Something else to keep in mind, your SSRI, your antidepressants, such as your Celexa, etc., can sometimes worsen REM sleep behavior disorder. Restless leg syndrome, there is a pretty high association between Parkinson's and restless legs as well. Of course, many patients with RLS do not really develop Parkinson's, but it is quite commonly seen. So typically what we do is, now restless leg syndrome is a condition where you get this achy, gnawing sensation in your legs, which make you want to move your legs. So patients often report that they get to bed and they have to keep moving their legs, or their legs jerk, and they just cannot get comfortable and get to sleep. So we typically check iron levels or ferritin levels, which is a measure of iron stores. And if those are low or low normal, we supplement that. And then we can use your dopamine agonists such as Requip, pramipexole, or Nupro, in addition to gabapentin and clonazepam, which can also help reduce the restless leg symptoms. As time progresses, sometimes these restless leg symptoms can happen earlier on in the day as well, so you might need more frequent medications. One thing that we do not recommend specifically for restless legs alone is levodopa. So if, hypothetically, if a patient was predominantly bothered by the restless legs, then I would not increase the levodopa for that. I would rather put them on the other medication, because sometimes levodopa can make restless leg symptoms worse. All right, so talking about impulse control disorders, it is very important to be vigilant for this problem. The main reason it happens is because of dopamine. So in Parkinson's, dopamine is the chemical that's deficient. However, dopamine is also the chemical that's involved in the pleasure and reward pathway. So when you give these medications like levodopa or Requip, etc., in addition to stimulating the receptors involved in the motor function, they also stimulate these other receptors to a lesser extent, but they still do. And also, which as a result of which you can have multiple different symptoms. Now, typically for these, we can try antidepressants or some other medications such as the quetiapine, but these are very difficult to treat with medications. Often we have to reduce or switch your dopaminergic medications. So impulse control disorder, a large study that they did in 2010, which enrolled over 3,000 patients, estimated that the prevalence of ICD or impulse control disorders could be as high as 13%. And what they found was that patients that were treated with dopamine agonists, such as the Requip, Mirapex, or Nupro, had a higher incidence or had a higher prevalence of impulse control disorders compared to those who were not treated with those specific medications. So levodopa by itself is less likely, though it can still happen. But the dopamine agonists or dopamine mimics, they have a higher chance of causing impulse control disorders. Overall, there's no significant difference between Requip and Mirapex, but a different study showed that maybe Nupro patches might be associated with a lesser risk relatively. So what are the risk factors? Who might be at a higher risk of getting impulse control issues? So early onset Parkinson's, younger patients, males, unmarried, people who have a history of alcoholism and smoking, who have a prior history of addictions to other things, comorbid psychiatric conditions or novelty-seeking personality traits. These people might be at a higher risk of developing impulse control disorders. So you could have pathological gambling or aberrant sexual behavior, and males are more likely to have these. And in the study, what they found was that women were more likely to have compulsive shopping, buying, and binge eating. So if you have any of these conditions, it's very important to bring it up with your physician because these are caused by the medication. So I've had patients where they don't tell anybody that they've been gambling away thousands of dollars online, or they've been shopping, they've been buying things that they don't really need, they've been hoarding up stuff. So it's very important to be cognizant of the fact that these symptoms are caused by medications and they're easily treatable by reducing some of your medications. So we typically counsel patients about these potential issues. And as I said earlier, reducing your dopamine agonists or your Requip, etc., will often help reduce these symptoms significantly. We might have to increase your levodopa doses as long as the levodopa doesn't contribute to impulse control issues as well. I've had a patient who went into the store to buy a toy for his grandson, and he ended up trying to walk out of the store with 2 carts full of stuff that he didn't really need. So it's very important to be very aware of this. I had another patient who ended up having to surrender his driving license because he kept going to gamble. So this is a very real symptom that we have to be careful about. So, for example, limiting access to money or internet is something that we recommend to family members. Evidence for pharmacotherapy as a medication is limited. As I mentioned earlier, certain medications like quetiapine, risperidone might be potentially useful, or antidepressants. DBS is a challenge. So for example, deep brain stimulation is a surgical procedure that we do for Parkinson's patients. And one thought process is that if we did DBS, then we might be able to lower some of the medications, which in turn would help reduce the impulse control issues. But there's been a lot of mixed data about this, whether some studies have reported that doing so made a difference, that the impulse control issues got better. But some studies have also reported that the impulse control issues got worse after going through DBS. So at this point of time, I typically don't put a patient through DBS if they have active impulse control issues. And I'm going to finally talk about dopamine dysregulation syndrome. This is not very common, but basically what happens in this condition is that people start taking higher and higher doses of levodopa. And the reason they're increasing the dose is not because they're truly needing it from a motor standpoint. It's not that they're truly shaking more or they're truly having significant gait issues, but it's more of an addictive pattern. So we sometimes see patients who are badly dyskinetic, who say that they need to keep taking their medication, even though they are badly dyskinetic, which is more of an addictive pattern of dopamine use. Again, as I mentioned earlier, dopamine has effects on the reward pathway as well. So in addition to impulse control issues, it might also cause a dysregulation where you feel the need to keep taking dopaminergic medications. Right? So the way we diagnose it is needing higher doses of dopaminergic medications in excess of what we typically require to treat Parkinsonian symptoms, expressing need for increased medications in the presence of significant dyskinesias, where despite clearly being on already, impairment of social and occupation functioning because of the addiction, development of hypomania or manic states where you're on a high, you just cannot stop, you're too active, you cannot sleep, you just want to keep doing something or the other. Or cyclothymic, as in you have big swings, you have depression and then you're manic because of the medication. Or withdrawal states, where if you've not taken your medicine, then you're on the other end, where you're extremely depressed, extremely anxious, irritable, etc. So typically for that, we mainly just recommend gradually lowering the medication and counseling patients to make sure that they understand that these symptoms are caused by the medication itself. That's basically my talk. I'd be happy to take any questions.
We do have some questions. So one of the first questions is someone asked about that this person has dry mouth, but not drooling. Do you have any recommendations for that?
So you can also use, you get like lozenges and stuff like that, mouthwashes that you can use to moisten the mouth. Or even sometimes chewing or chewing gum, etc. might help because it stimulates saliva production as well.
And then you did go over the treatments, but I'm guessing this person missed it, the treatments for the hyperhidrosis, the excessive sweating. What do you suggest for that?
It's mainly, you could use pills, but if not, there's a pill called glycopyrrolate that we could try. If not, seeing a dermatologist for Botox injections into like the palms or the axilla, the armpits, that might help reduce some of that sweating.
Someone asked about the autonomic dysfunction that fits into the non-motor symptoms, especially around temperature control with excessive heat and chills or sensitivity to temperature. Could you talk a little bit about that?
Yeah, unfortunately, not a whole lot that you can do about that. That could happen. You also want to make sure there's nothing else going on. You don't have any neuropathy or something like that. Sometimes people with neuropathy might feel that their hands and feet are going colder than they are. So that is something else to rule out. But kind of the whole body thing, yeah, there's no other treatment for that as such.
This is always interesting to me because I've seen that in practice. Someone asked about, what about using the antipsychotic medications for visual hallucinations if they aren't threatening? I remember way back when there was a patient and she would see this cat, and the nurse practitioner I was working with is like, well, we can take care of that. And she's like, you're going to take my pet away? Because like where she lives, she couldn't have, pets. So this was a good thing. And then we move forward a few years and she has to move in with her daughter because she's worsening. And all of a sudden at this point, the cat is suddenly starting to misbehave. And the daughter was like, we got to take care of this. She says the cat is peeing on the bed and I have to change the sheets like 20 times. And she's like, cat's not real. Like, what do we do here? What happened?
Yeah, that's very difficult. I typically, if somebody's having hallucinations, I would prefer to address it. In the earlier stages, often, as you said, there's insight. You know that that's a hallucination. But if you just let it linger, then there's a risk that it's going to just keep getting worse to the point where the insight is lost. So if somebody has hallucinations, I would rather go ahead and treat. So either with the quetiapine or maybe the pimavanserin. The advantage of pimavanserin relatively, or Nuplazid is what the brand name is of pimavanserin, is that it doesn't block some of the other chemicals that quetiapine does. So it's less likely to cause drowsiness in most patients. But yeah, I would definitely go ahead and treat it. Now, if it was something that's rare, happens, once a week or once a month, then okay, maybe then there's no advantage of putting the patient on a daily medicine. But if it's something that's pretty consistent, then I would rather go ahead and treat rather than wait until it gets to the point where they've lost insight.
And then another person asked if you could talk about abulia, which I don't know if I'm pronouncing this right, the lack of will, drive, or initiative for action, speech, and thought that can come, like the apathy that can come with Parkinson's. Can you talk a little bit about that?
Right. With apathy, yes, it comes with Parkinson's disease, but typically we don't really do anything about it other than just trying to motivate that person. Family members, and I tell it to tell the patient right there in front of the family members that, hey, they're going to get after you to exercise and do things. It's because you're not doing it. So, because sometimes what happens is that caregivers will say that I keep trying to push him or her, and then they get upset at me that, oh my God, why are you getting on my case? Just let me be. So it's very important to identify that lack of motivation is part of the Parkinson's. I really am not a very big fan of using stimulants unless we absolutely have to.
Talk a little bit about baclofen. We had a couple of questions. Someone asked, are there issues with using the Tylenol, baclofen, and naproxen together? And someone asked, does it work as an occasional like PRN as needed medication, like when the dystonia is bad, or is it more effective to take it every day?
You can use it as needed. It's fine. And you can combine, they work in different mechanisms. So you could combine those if you needed to.
You had talked about leg swelling. Does leg swelling in only one leg occur with Parkinson's disease if other things have been ruled out? Is that common where it might just occur in only one leg?
Unlikely, unless you've had maybe surgery or something where those veins and the lymphatic drainage has already been relatively affected from prior surgery, if you had knee surgery or something like that. But definitely if it's something of recent onset, then definitely I would make sure that there's no blood clot causing the swelling. That would be my biggest concern if it's only on one leg.
And then someone asked, with advanced Parkinson's, like 16 years, and then also dementia of 3 years, is there anything that can be done to slow down the progression at this point?
Unfortunately, in terms of progression of Parkinson's, there's not really a whole lot we can do. So medications and physical therapy help delay disability in Parkinson's. So they kind of slow down progression in that fashion. But they slow down progression of symptoms rather than the disease itself. So the degeneration in the brain that's happening, there's nothing that we can do to slow that down. In terms of the dementia, definitely trying to stay as mentally active as possible, doing puzzles, crosswords, etc., to give you that stimulation is very important.
Back to the excessive sweating. Could medicine cause the excess sweating?
I don't know. I mean, sometimes some people might have some issues with that, like with some antidepressant maybe, but I would have to look at the medication list. It's without knowing what the interactions there might be.
That might be something to take up with their doctor.
Yeah.
Okay. And then, so I have always heard that there can be a reason to delay the use of levodopa. And someone said that we hear frequently now that there is in fact no reason to delay the use of carbidopa levodopa as long as possible. Versus having patients go through the dopamine agonists and stuff. Is this finding gaining acceptance in the medical community? Is this even the case at this point where they are finding that it isn't? Because I was under the impression you kind of wanted, especially in young onset, to delay the carbidopa levodopa for as long as possible to reduce the chances of dyskinesia later.
Right. So, but there's some more nuance to that. So typically the theory now is that there's no reason to withhold levodopa on any patient. Levodopa is our most potent medication in Parkinson's. It is relatively better tolerated than your dopamine agonists. So there's no reason to withhold levodopa. Now, the risk for dyskinesia is tied not to how long you've been on levodopa. It's related to more so the disease duration and the dose of levodopa. So if you put somebody on, say, 4 pills of levodopa and they've had Parkinson's for X number of years, they are probably less likely to have dyskinesias as opposed to somebody who's been put on, say, 8 tablets of levodopa. So what I typically do for most patients is that I start them off on levodopa. And then if I feel that they aren't doing as good, then I might go up on the levodopa by a little bit, or I might add other medication that work in other mechanisms at a later stage. But I don't delay the use of levodopa just because of the fear of dyskinesias, because it's more so the disease duration and the dose.
And since we're talking about it, I do just want to clear up and have you just confirm. People will say that you get a tolerance to carbidopa levodopa, and it's really not that you need more because you have a tolerance, it's that you're progressing in the disease.
Correct. So yes, so it's not that your body's getting used to the levodopa. It's more so the fact that your disease progresses, so you end up needing higher doses of levodopa because that the dopamine deficit is becoming larger, number one. Secondly, as Parkinson's progresses, those receptors where levodopa is supposed to go and work on, they themselves also start to function to a lesser extent. So the combination of that makes levodopa less effective. So I would rather use levodopa at an earlier stage, have my patient be more functional and thus delay disability from Parkinson's, as opposed to waiting too long and then trying to catch up.
Once just asked about, does Rytary cause sleep attacks? I guess because that's a good way to maybe increase on times. Is that linked to sleep attacks?
So levodopa in general has been associated with potential drowsiness, even dopamine agonists as well. So Rytary is basically just carbidopa levodopa. So it could result in extreme drowsiness, but I would say it's relatively less common. I mean, it's not going to be the point where you just drop asleep from it, and that's where it's important to stay active, especially in the middle of the day. You want to stay active mentally and physically to reduce the drowsiness.
One thing that comes up a lot, you did touch on the REM behavior disorder. I know people they've had to sleep separately because of it. Can you talk about just, a little bit, you did touch on how to control it, because I know that's very, people don't like to talk about the fact that they're like, we can't sleep together anymore. I become violent in my sleep in a way. And that's kind of a big deal.
Exactly. Yeah. So REM sleep disorder happens because you're acting out your dreams, right? So typically your body is limp during your REM sleep, which is your dream phase. But then in REM sleep behavior disorder, that atonia, that with the body being limp, that feature is lost. So that's why you end up acting out your dreams. And this can happen for even years before the onset of the motor symptoms. So typically I start off using melatonin. I suggest, say, let's just try something natural, try melatonin, 5, 10, or even 20 milligrams of melatonin and see if that does the trick. If not, then clonazepam often works pretty well for that. The clonazepam, only thing is sometimes some people feel drowsy the next day, but usually with the clonazepam, we can reduce the REM sleep behavior disorder significantly. So, and then I would also recommend other measures, like making sure your bed has rails, making sure you have pillows, etc., to make sure that you don't injure yourself.
Someone asked about parasomnia. Is that
Parasomnia is basically a sleep-related abnormal behavior. So REM sleep behavior disorder is a parasomnia. There are other parasomnias which can happen, but not with Parkinson's disease.
Somebody did mention that falling asleep during the day can also be due to low blood pressure. Because you did talk about the orthostatic hypotension.
I mean, in general, if your blood pressures are very low, then you would be fatigued and sleep. I guess that could happen.
Okay, I've not heard that. Normally, I always thought of the orthostatic hypotension was more of a concern when you stood up and you kind of fell down because it was
right.
faint.
But that's what orthostatic hypotension is. But in general, if your blood pressure runs low from being on anti-blood pressure medications, and so if your blood pressure is low even when you're sitting to begin with, then I guess you would feel tired because of that. That's probably not so much the Parkinson itself.
We are almost out of time.
Just to add on with regards to that, the dopaminergic medications like levodopa, all of those can also sometimes cause lightheadedness, dizziness, and worsen the orthostatic hypotension. So if something like that happens, then the easier option is to leave the patient on the levodopa and reduce their blood pressure medicines instead.
Thank you so much for taking the time to speak with us today. This has been so educational and so informative.
Thank you.
As always at PMD Alliance, we have our tradition, our wave of gratitude. Thank you so much for being here today. We really appreciate it.
Thank you very much. Thank you very much. It's my pleasure.
Bye.
Bye.